Hi, this is Karen Hines with Southern Anesthesia Seminars. This is just a quick update on neonatal resuscitation algorithm. My goal here is to help you feel more comfortable if you ever find yourself in an emergency situation with a neonate. The first thing you want to do is identify any infant that might be at high risk for needing resuscitation. So you want to look at maternal risk factors and fetal risk factors. Then at birth, you want to evaluate their gestation, their tone, and their breathing. If they have if they're a term baby, they have good tone and they seem to be breathing well, then you can go ahead and leave with the mother and proceed with normal newborn protocols. This still includes keeping them warm and clearing secretions, that kind of thing. Now, if the answer to these questions is no, they are not term, they don't have good tone, and you notice that they have trouble breathing, they might have retractions, nasal flaring, anything like that, then you want to initiate the steps of neonatal resuscitation. This includes warming the baby. You want to position the airway into the sniffing position, clear any secretions, and start to dry and stimulate the baby. So after you've taken the previous actions, you want to evaluate the infant's breathing again. Are they apneic? Do they are they gasping for air, or do they have a heart rate less than 100? If the answer to any of these questions is yes, then you can go ahead and initiate positive pressure ventilation at about a rate of 40 to 60 breaths per minute and begin to monitor their oxygenation. And keep in mind that oxygenation for babies can take up to 10 minutes to reach normal or peak oxygenations, and supplemental O2 should be administered based on target SpO2s during that first 10 minutes of life. Now, if they're not apneic, are not gasping for air, and have a heart rate greater than 100, then you still want to evaluate their breathing. Is it a little labored? Do they have a little retraction, maybe some nasal flaring or persistent cyanosis? If the answer to these questions is yes, then you want to go ahead and reposition the airway, provide some supplemental O2, again, based on those target guidelines, and maybe consider CPAP. If at this point the baby's maintaining on their own, then they can go ahead and proceed to post-resuscitative care, and you can do a team debriefing. All of these steps should take less than 60 seconds to get through. You want to move quickly through assessing the vital signs and symptoms that you're looking for and move on to the next intervention pretty quickly for neonates. Next, you want to evaluate the heart rate. Is the heart rate less than 100 beats per minute? If so, then you want to check for chest movement. How good of a chest rise do you have? If you're not ventilating well, then you may have to take some corrective measures. You may need to put the baby more in the sniffing position, check the seal on your bag mask. And if you still can't get a good chest rise, you may need to consider an ET tube or LMA. If the baby's heart rate is greater than 100, then you can go ahead and proceed to post-resuscitative care and team debriefing. During this, you want to identify any underlying causes or any continued monitoring that needs to be done, anything that could have been done differently or prevented the need for resuscitative measures. If the heart rate continues downward and reaches the point where it is less than 60 beats per minute, then you want to go ahead and intubate if that has not already been done, and begin chest compressions. And you're going to compress at a rate of 90 to 100 beats per minute. You can either use the 2-finger technique or the thumb technique. You want to make sure that your chest compressions are coordinated with positive pressure ventilation using a 3-to-1 ratio, so about 90 compressions to 30 breaths per minute. If you have to initiate chest compressions, then you need to go ahead and go to 100% FiO2 and forget about the target oxygenation. You want to apply EKG monitors and consider a UVC because you can administer drugs and fluid boluses through that much more easily. If the heart rate is not less than 60, then you can go ahead and go back to the previous point on the algorithm where the heart rate is less than 100 and reevaluate and follow the algorithm again from there. So the next step is epinephrine administration. If the heart rate remains below 60 beats per minute despite adequate ventilation, then epinephrine is indicated. So the dose of epinephrine is 0.1 to 0.3 mLs per kg of 1 to 10,000 epinephrine IV. At this point, you also need to consider what is causing the infant to continue to be compromised, because most infants will respond very well to proper oxygenation. So you need to consider possibly hypovolemia, pneumothorax, or any other underlying condition that could be contributing to this prolonged need for resuscitation. If the heart rate is not below 60 beats per minute, then you can return to the previous point in the algorithm, less than 100 beats per minute, and reevaluate the infant and follow through the algorithm from there. Also, just to note, if you do administer IV epinephrine, then you want to go ahead and continue chest compressions for another 45 to 60 seconds to make sure that the epinephrine is circulated. So this concludes our quick update on neonatal resuscitation algorithm. I hope you found this information helpful. If you would like more in-depth information on neonatal resuscitation, please visit our website at southernanesthesiaseminars.com. We do have a 1 CEU course available there. It is based off of NRP guidelines, but it's geared towards anesthesia providers. It will give you a more in-depth pharmacology and physiology on neonates. We also have a neonatal code card that you can download. It's meant to be like a pocket guide. It has the endotracheal tube size, some drugs on the card. It's available at our website. Again, that's southernanesthesiaseminars.com. Please visit us there. Also, if you have any comments, questions, concerns, any feedback at all on this presentation, please email me at southernanesthesiaseminars@gmail.com. Again, if you have any comments, questions, concerns, feedback on this presentation, please email me at southernanesthesiaseminars@gmail.com. And we hope to see you again at another update from Southern Anesthesia Seminars.